Hi, I'm Stephanie Cornell, and I'm a physiotherapist on the SCI team at Parkwood Institute. Together with other members of the Research to Practice team and colleagues on the SCI team, I have led an implementation project in the domain of walking and wheeling mobility as part of the Provincial SCI Quality Care Consortium.
The SCI Consortium is a provincial network of practitioners, persons with lived experience, leadership, and researchers committed to improving health outcomes of individuals with SCI. Across multiple health domains, some of them listed at the bottom, the team works together to implement best practice indicators at their local site. Our Parkwood team is working across several domains simultaneously. The results today presented are specific to walking and wheeling. The aim of implementing changes in the walking therapy practice is to maximize recovery of walking following a spinal cord injury. In order to measure a site's capacity to implement best practice recommendations, 3 indicators were rolled out at each site. Each indicator captures a different aspect of the practice. The biggest gap identified at our site was the process indicator, the number of minutes in therapy a patient participated in walking interventions. Physiotherapists record what activities are done in therapy, but up until the initiation of this project, did not record number of minutes spent in each intervention. This was a priority area for us to target, not only to get baseline information, but to create a system that will allow us to measure what works and what doesn't in therapy.
The aim of the wheeled mobility domain is to maximize community wheelchair mobility. Similar to the walking domain, one of our largest gaps was the capture of time spent doing wheelchair skills in therapy. The other gap in current practice was the use of the Wheelchair Skills Test Questionnaire as a standard outcome measure in rehab. We formed a local site implementation team consisting of frontline clinicians, persons with lived experience, and researchers who met bi-weekly to review current practice and work through implementation strategies. Simultaneously, the provincial team met bi-weekly to share experiences and discuss common barriers to implementation across all sites.
Changes to the flow sheet addressed gaps in the process indicator, and we were able to begin measuring how patients were spending their time in therapy. But we still needed to implement regular use of the Wheelchair Skills Test Questionnaire. It is considered best practice to complete this questionnaire prior to discharge from a rehab unit. However, it emerged that our therapists did not feel comfortable teaching some of the skills that could be identified as goals. We conducted a staff survey to determine the skills they felt they had low confidence in teaching.
All PTs, OTs, and assistants on the spinal cord injury team were part of the staff training module. The training consisted of an orientation to wheelchairs and seating systems, as well as practical skills training in manual and power wheelchairs. Results of a post-training evaluation showed that staff had increased confidence in their wheelchair skills training abilities following these sessions. In order to address the gaps in recording of therapy activities, our implementation team redesigned the daily therapy flow sheets used by our OTs and PTs. A coding system was created, and PTs indicate with a check mark all activities related to the goal of walking. Wheelchair-related interventions were recorded on the last row and coded to indicate whether the intervention was face-to-face, non-face-to-face, or wheelchair skills training specifically.
This graph shows preliminary data from the collection of therapy minutes. Along the bottom is the patient's standing and walking assessment tool, or SWAT stage. This is a staging tool used to indicate a patient's functional status. We can now get baseline information about how patients are spending their time in therapy, and then use this data to continue to drive practice improvements on the program. Gathering real-time data and involving frontline clinicians and persons with lived experience in the analysis of the data has led to more reflective practice and will promote data-informed decision-making in the long term. The implementation initiatives supported by the SCI Consortium is important work and will continue to improve the lives of those living with SCI.